Let's pick another most important topic: sarcoma. Soft tissue sarcoma, rare, unusual neoplasm of soft tissues. Most common site: extremity, lower is more than upper is more than trunk. Retroperitoneum is more than head and neck. And most common type: liposarcoma is more than glioma. Sarcoma is more than synovial. Sarcoma is more than malignant. Peripheral nerve sheath tumor is more than malignant. Fibrous histiocytoma is more than cyst. Most common pediatric soft tissue sarcoma is rhabdomyosarcoma. The heterogeneous spread is typical of sarcomas. Histopathological type of STS is site dependent. Extremity uh, malignant fibrous histiocytoma is more than liposarcoma, and retroperitoneum liposarcoma visceral cyst. Pathology: STS tends to grow along facial planes with the surrounding soft tissue compressed to form a pseudocapsule. Clinical behavior of STS is determined by anatomical location, depth, grade, and size. Most common route of spread in soft tissue sarcoma is heterogeneous. Most common site of metastasis, lung lymphatic metastasis, is rare. Clinical features: most common symptoms of STS: painless mass. Size at presentation is dependent on the location of tumor. Smaller tumors are located in distal extremities. Larger tumors are detected in proximal extremity and retroperitoneum. Retroperitoneal STS almost always present as large symptomatic mass. Diagnosis of soft tissue sarcoma: core cut or true cut biopsy, CT or USG guided is diagnostic. Incisional biopsy is done if core cut biopsy is non-diagnostic. FNAC to confirm or rule out presence of metastatic focus or local recurrence. MRI, IOC investigation of choice for accessing extremity STS, CECT, IOC for accessing retroperitoneal sarcoma. Adequate excision plus adjuvant radiotherapy with or without adjuvant chemotherapy. Two most active chemotherapy agents against STS: doxorubicin plus and ifosfamide. Prognosis: best prognostic factor of soft tissue sarcoma. Grade: best prognosis seen in extremity STS. Most important predictor of metastasis in STS. Grade: most common cause of death in STS. Whilst metastasis, 5-year survival rate for STS, all stages 50 to 60%. Another page. Sarcomas within lymph node metastasis. Most common site of metastasis in sarcomas of extremity lungs. Most common site of metastasis in retroperitoneal sarcomas. Liver is more than lungs. Lymph node metastasis is uncommon in soft tissue sarcoma. Sarcoma with lymph node metastasis. Marcus. Malignant fibrous histiocytoma. Angiosarcoma, rhabdomyosarcoma, clear cell sarcoma, epithelial sarcoma, synovial sarcoma. Rhabdomyosarcoma. Rhabdomyosarcoma arises from mesenchymal tissues. Most common site of origin: head and neck. Parameningeal is more than extremities, more than genitourinary tract is more than trunk. Most common pediatric soft tissue sarcoma is rhabdomyosarcoma, associated with NF Beckwith, Whiteman, syndrome, leishmania, and fetal alcohol syndrome. Pathology. Most common histological type embryonal rhabdomyosarcoma. Most common type in adults, pleomorphic variant, and diagnostic cell is rhabdomyoblast. May contain tadpole cells or strap cells. Embryonal type consists of a spindle cell variant and sarcoma. Botryoids. Tumor cells resemble tennis racket, and tumor cells form submucosal zone of hypercellularity known as cambium layer. Best and most special marker for RMS. Myosinine is more than MYOD. 1 is more than desmin. Clinical features. Most common presenting symptoms. Mass may or may not be painful. Bimodal, first peak between 2 to 5 years, second peak between 15 to 19 years. Extremity RMS are more common in lower extremity. Most common site of metastasis, lung. Diagnosis. Diagnosis is confirmed by biopsy, MRI, IOC for diagnosing extent of disease. CT used to rule out lung metastasis. Treatment: wide local excision of tumor with surrounding involved tissue. Tumor not amenable to primary excision. Neoadjuvant chemotherapy after tumor has decreased in size, resection of gross residual disease. Radiation therapy, when microscopic or gross residual disease exists after initial treatment. Prognosis. Prognosis is related to the site of origin, resectability, presence of metastasis, number of metastatic sites, and histopathological features. Embryonal variant is favorable, and alveolar type has an unfavorable prognosis. Favorable primary sites and unfavorable primary sites. Favorable primary sites RB, non-parameningeal head and neck.